So I request HOD sir from Salem Medical College. We are going to have some interesting different aspects of snake bite management. I hope we'll be getting some interesting cases from the institutions.
Good morning. Good
And
evening
if
to
there's
all.
any question from the audience also, we'll be welcome, most welcome. Yes, sir.
Good evening to all. My presentation is similar to our Pudukkottai presentation. So, next slide. So, a snake bite discussion from Government Mohan Kumar Medical College, Salem. As our TOY initiative, our incidence of snake bite deaths are reduced. As already pointed out by the previous speakers, almost all the periphery government hospitals and hospitals, they are giving anti-snake venom, but not up to the adequate dose. Still we are facing the problem. Last year we arranged a snake bite and poisoning management classes by the TOY center through all the medical officers. I think we can arrange some follow-up studies also for this year also. Next slide. So this 56-year-old male admitted in the Namakkal Government Medical College Hospital on 13/4/25 at 9 p.m. in view of unknown bite around 11:15 a.m. near his residence. Site left upper limb ring finger with swelling and pain. Whole blood clotting time was more than 20 minutes and he was given 10 ASV vials. Followed that he developed hematuria and again he was given 10 ASV vials as per the protocol. But in the subsequent events, he developed a decreased urine output and acute renal failure of 46, urea 46 and creatinine 2.8. The patient was referred to Salem Medical College next day, 2:15 p.m. in view of the swelling, persistent swelling with multiple episodes of vomiting with the features of hematuria and elevated renal parameters. Next slide. The past history, patient doesn't have any comorbid illness. The general examination was normal. RS only, the few scattered crabs and the vitals are stable. And at the receiving time, the whole blood clotting time was 20 minutes, less than 20 minutes, but he has a cellulitis along with hematuria with a decreased urine output. Next slide. So this presented at the time, the total count was elevated, INR was elevated 1.82, urea 85 and creatinine 5.3. So he is having acute renal failure with less platelet count and increased total count. Next slide. So these are all the serial evaluation. The hemoglobin was 10.3 to 8.7, 7.5, 6.8, 6.3, 6.8, 8.3. The peripheral smear study done was normal. Total count was, initially it was 14,400. Now it was 8,800. The platelet count started from 0.59 to, now it is increased to 1.33. The urea creatinine was steadily declining, steadily increasing 5.3 to 195. And the creatinine value was 9.3. Next slide. So the patient was, after receiving, we gave another 10 vials of ASV in view of hematuria, and the ASV, with the ASV, the nephrologist opinion obtained and the first cycle of hemodialysis was done. Subsequently, next day, in view of persistent hematuria, we gave 4 units of FFP. Since the 30 vials of ASV is given, so the urine output was only 100 ml. He underwent second cycle on next day, 16th. And subsequently, so far he went 5 cycles of hemodialysis. And now, day before yesterday, the urine output was steadily increasing and he is having clear urine. But the creatinine value was still, it was high, 8.9 only. It was shown by the previous slide. Next slide. So the investigation which shows 15/4 urine albumin 3 plus and RBCs was there. Urine albumin, subsequently the RBCs shown 17th also 5 to 6. Blood culture, growth of Klebsiella pneumonia was there. Ultrasonogram abdomen which shows increased in cortical echoes and mild minimal pleural effusion with the fluid in the peritoneal cavity. And the chest X-ray bilateral blending of costophrenic angle, evidence of pleural effusions. Next slide. So the treatment so far given was 30 ASVs with 2 PRBC transfusion. It was given at Namakkal Medical College itself. 4 FFP transfusion and injection piptas, metronidazole, ranitidine and chimeral fort and serratiopeptidase and other conservative managements. So the next slide. The diagnosis was made as snake bite with left hand cellulitis, chemotoxicity, capillary leak with acute renal failure. But the patient is clinically improving with increased urine output and with clear urine, but the renal parameters were still not settled. He is under observation in our medical college still now. Next. So currently the patient on further monitoring and treatment dialysis is going on up to 22. Patient parameters and urine output is steadily improving. This was the presentation, sir. It's almost similar like our Pudukkottai presentation. We are getting cases in the nearby medical colleges with Sir Mohan sir told that the compartment syndromes and all, nowadays we are getting very rare and things. Even the last year itself we have got several compartment syndromes, especially we are getting cases from Kallakurchi areas, Sinna Salem, Kallakurchi, like that areas, the snake bite, which they are referred. Most of the cases are going for compartment syndrome. We did fasciotomy for some of them, and that patients are also having very high mortality, sir.
Sendil.
It's a very good case and very good so management, sir. So probably this patient also had, as discussed, thrombotic microangiopathy. So probably if a peripheral smear study, if it was done, it would have.
It was normal, sir. That's what
So normal.
told.
Yes, sir. Probably that VECC component along with the pigment component would have aggravated this patient, sir. Very good approach.
So regarding this patient, sir, you told the comorbidities was not there in this patient. So considering local envenomation with sepsis, cultures are also positive. So whether any renal involvement other than snake venom induced can also be considered like acute rapidly progressive glomerular nephritis, where nephrologist.
That's what in the previous case also, then the Pudukkottai also, the similar presentation. Some of the cases are producing rapid progression of the elevated renal parameters. So we don't have any previous data like that. According to our knowledge, the patient doesn't have any previous history of renal involvement. We inquired that also. Because still now the creatinine value was 8.9.
Yes, sir.
Patient was not improving. Some of the cases after not improvement or the 15 days, we are going for renal biopsy, shows acute tubular necrosis, and the findings are not reversible also.
So with the renal biopsy, you have evaluated the case.
Yes, sir. Planning for renal biopsy, if the patient was not, the parameters are not improved.
Yes, sir.
We are waiting for
We can have a
that.
series of cases like this where we can have, it can throw light.
Yes,
on
sir,
what is
definitely,
happening to the
definitely,
patient.
sir.
Yes, sir. Said the direct venom toxicity on the glomerular, probably that is a case, and there are studies that literally less than 5% of these cases can progress into CKD.
CKD, yes, sir.
So,
yes.
so biopsy is very much
Biopsy
important.
is
Sir.
very much.
Sir, we gave FFP, no, sir? Indication was INR was 1.8.
INR and he having persistent hematuria also.
Persistent
That presented
hematuria
the patient referred from there, Namakkal Medical College, it was itself a multiple episode of vomiting with a progressive cellulitis with hematuria, with elevated renal parameters. So already 30 vials given. So persistent hematuria, we gave 4 FFP on the next day, 16th.
After that improved, sir?
No, it was improved, sir. Now he is having clear cut.
So after listening to your case, you are talking about a capillary leak syndrome, especially they say in Malabar pit vipers, because when we go to Kerala conferences, they say one of the feature of this is periorbital edema. So was the periorbital edema was noticed in this case? Only a pleural effusion was noticed. So sometimes in the Western Ghats area, districts closer to that, whenever a snake bite comes, look for periorbital edema. It may be early sign of capillary leak syndrome. That is one thing. And
That's presented with the unknown bite, sir.
yeah, okay. Okay, that is one thing, sir. Regarding FFP, because many times, after completing 30 vials, still the WBCT may be prolonged. I think Dr. Ramesh can throw some light. We have given FFP for them also when still the whole blood clotting time is not there.
Yes,
I mean,
once we have completed the maximum dose of ASV, still the patient is having coagulopathy or multiple etiologies can be there to persistent having coagulopathy, where FOP can be the management for preventing organ bleeds.
organ. because I have seen, being working at tertiary care at Madras, we have seen sometimes people referring to us with 60 vials given outside because WBCT was prolonging. So everywhere they go, they have been giving 20, 20, 20. So when they landed in our hospital, they came with 60 vials also. So the message is, if you after 30 vials, if it is still not clotting, go for FFP. Can we suggest that, or you have any comment on that?
Sir, it depends on, suppose if it is a known Russell's viper or Saskale viper, then the scenario is different.
Yeah.
Where we have given 30 vials,
Still,
we have seen the snake confirmed.
okay, yeah.
Or some lab parameters suggest of probably Russell's viper or Saskale viper. 30 vials we have given, still patient is having 20-minute WBCT positive. We can give 10 more, 40, 50. So very, very rare that is. FFP role will come only if there is a significant large cavity bleeding, that is after you have given 30 vials of ASV. If there is no bleeding, only test is positive, in confirmed case of Russell's viper, Saskale viper, you can give ASV more than 30 vials.
So one more doubt, if there is any other indications for giving excess of ASV other than this prolonged clotting time? You said that after the clotting time was prolonged, even after 30 vials, you are proved that the patient is having classical Russell viper fight.
Yes.
So you can go for 40 or 50 vials, depends
sometimes.
upon the condition. I am
Sometimes,
asking
sir.
about whether there is any other indication other than this prolonged clotting time.
CR wants to add, please, sir.
No, I don't think we are justified in giving more than 30, sir. Because the maximum venom quantity that can be injected by a adult, healthy, active as a first bite on a victim, definitely the 30 itself is more than sufficient. So this kind of neutralizing capacity of this polyvalent anti-snake venom and its efficiency against the viper, I don't think we need to give more than 30.
Correct, sir. Because on an average, it can give from 4 to 157 mg.
Yeah, that's what.
On an average 63 mg, that is the maximum amount it can be injected into the
Yes,
body.
yes.
Each vial going to neutralize 6 mg of
Yes,
venom.
yes.
So based on that only 10 vials has come.
Yeah.
Maximum you can give up to 25 to 30 vials. That is been calculated.
yeah.
But sometimes where you are given 30 vials, still patient is having 20-minute WBCT positive. Coagulopathy is still present. Rather,
You manage it like any other coagulopathy rather than going on increasing the dose of ASV. That is our
but for the
kind of
blood
understanding.
products to be given, sir, there are specific indications written. That is, if there is a always bleeding, clinically significant bleeding, we can give, sir. Just based on the PT INR, may not be advisable to give blood
Actually,
products.
this is where we don't have a strong evidence for or against. So this kind of forum can bring out some data and you can practice whatever you are finding. I think Dr. Sendil wants to add before.
One minute, sir. Why I asked this question means, my previous nephrologist in our hospital, he said in his experience, even after 30 vials, if you are giving more vials, that will be useful for acute kidney injury. That's what I asked for this question.
Yes, sir. Yes, sir.
So basically, as explained, VACC is going to happen, and basically there is going to be exhaustion of all the clotting factors. So there is bound to be a bleeding tendency. So we may not know whether the venom component is causing the bleeding tendency, or there is an exhaustion of these clotting factors
Clotting,
that
that's
is
what-
responsible. So whenever a patient is having an active bleeding tendency, as in this case, patient had an hematuria, so you may start ASV along with FFP. So we have seen many cases who have developed an ICH or something like this when such patients probably after 24 hours. So probably this may help us. But if we have some assays to assess the unbound toxin fraction, probably in EIA, we may be able to justify the dose of ASV that has to be used. But usually when we have used a maximum dose as required, probably a 20 or a 30 vials, I think so that is far more enough. After that, if needed, probably the FFP has a role in the management whenever a patient has bleeding tendency.
Yes, sir. So regarding this, so we all know that the venom, the anti-snake venom acts on the circulating venom. Once it is fixed to the tissues, there is not much role for the further anti-snake venom for that. And another interesting scenario we also had is, so we have given the initial dose, we are waiting for 6 hours. In between time, there is active bleeding. So we are, actually we are waiting for 6 hours. So we are not going to give the another next dose of thing before 6 hours. In between also, any actual bleeding is there or organ bleed, we have envisaged. There comes a role for FFP in between period also.
Okay, at this moment I want to add one more dimension. Already one of our speaker was mentioning antivenom is not acting against some snakes in that area. I think it's a very crucial, important concept that we have to understand. At present, how our ASV are being manufactured, I think most of you may know that, but it's worth repeating. We are taking venom or we are catching snakes in and around our crocodile bank along the ECR road, and those snakes from our southern or some Chennai, near Chennai, they are the source for manufacturing of ASV across India. So we don't have a pan-Indian snake venom to be used as an anti-snake venom production. So definitely the venom from a snake caught in near Mahabalipuram may not work in Theni, or it may not work in Jammu and Kashmir. So that is another, that's a point Dr. Ajay Shelve was also morning mentioning. We are going to have a region-based anti-snake venom production based on the local snakes, and also every snake has its own enzyme. So many components are there, and we do not have antidote for all the specific things. So there are a lot of challenges in the administrative. What is available right now, only we are using it. But there are many things that we have to understand regarding the mechanism of action of these enzymes, and whatever we are talking about, FFP, all these are only supportive care we are trying to establish, and ultimately saving the life is the ultimate goal.
So
You are going to give one more case?
Sir,
or only one case?
So considering that point, that's the reason why, sir, because as I said, we don't know, once 30 vials are given and it is not working.
Okay.
I don't know whether it is a responsive snake or non-responsive snake.
That's what.
One thing, after scientifically we have neutralized the venom that has gone into with the 30 vials. After giving that, if we are going to dilute the protocol like that, giving another 10 vial or 20 vial, it will become like something anybody can do, anything like that. I think keep it around 30
That's
is sufficient to,
generally.
And then start with an FFB is an ideal one, rather than increasing the dose of an.
Okay,
Yes.
I think we had a very good discussion. We'll go to the next case presentation. Yes, sir. Time limit for?
There is a condition called late envenomation, as you are rightly telling. Where the patient can present late, in that case, what actually this anti-snake venom is doing, it can only neutralize the circulating free venom in the blood. When the venom gets fixed with the tissues, it is not going to act anymore, the anti-snake venom. So if you are getting after 24 hours or 48 hours, what we teach and practice is give 110 vials, first dose, that's it. There is no need to repeat. If the patient is coming to you or identified, already 48 hours are over, the venom is not in circulation, it is already gone to the tissue level, so it is not going to act. But still we give the benefit. There may be still some venom, may be in circulation, so we stop with giving the first dose. That's our teaching.
Actually, sir, I can highlighted this, the duration of action of venom, they have said up to 30 seconds a clinical presentation can be developed in case of crite and 24 hours in case of echo. So naturally we can go ahead with after one day also we can get the patient present you with more than 20 minutes clotting time, and the neurological presentation is there. As sir said, to neutralize only the existing venom that is present in the circulation, we can go ahead and give. There is no need for going further doses. That's what I'm saying. Even 24 to 36 hours we can go ahead.
Yeah. That's a point we are discussing. No.
So the T half of snake venom is only 14 hours, sir. After that, probably after 24 hours, if the bleeding is happening, it is probably because of VICC. And you will have to give a safe dose of, as sir said, 10 vials is probably in good faith that still there is some more unbound venom that is circulating. After that, it is only FFP.
If it is a neurotoxic snake bite, your mechanical ventilation take over it and can take it off. Only if there's an, for example, if it is a hemotoxic snake bite, as I said, the VICC is going to play a role. And again, the venom is not, I mean, antivenom is not going to be there. It's already the damage has happened. I think we can.